Good afternoon, everyone, and thank you for joining our ICTR Enrichment Seminar Series. For this presentation today, we actually have two guest speakers. We have Dr. Lawrence Vaughn and we have Ms. Molly Broche. Both of our guest speakers are coming to us from the BD Life Sciences Integrated Diagnostic Solutions. They will give us a little bit of background about what BD represents and its relationship to our campus. Dr. Vaughn will be our first speaker, and he will present cervical cancer screening in the era of the COVID-19 pandemic. And Ms. Molly Broche will be presenting clinical utility of testing symptomatic women for both sexually transmitted infections and vaginitis. Before we get started, I just want to let everyone know a few housekeeping rules. If you would like to pose a question, you can use our QA feature in your toolbar, or you can raise your hand. Also, feel free to add your comments or questions to the chat. We will be taking questions at the end of each presentation. In addition, when the presentation is complete and you go to sign out of Zoom, you will be redirected to our ICTR QA questionnaire, and we hope that you would take just a moment to give us some feedback about the presentation, and more importantly, what would you like to hear the ICTR present in the future. And with that, I'm going to allow our first speaker, Dr. Vaughn, to begin this discussion. Thank you, Dr. Vaughn.
Thank you very much, Wanda. Thank you, everyone, and welcome. On behalf of BDR Becton Dickinson, we're probably known to you as a medical company, but we also have a large diagnostic business. And back in 2019, we integrated two separate businesses, the pre-analytic systems and a molecular diagnostic systems business, into one integrated diagnostic solution. And pre-analytics is really about the tubes, the vacuum chamber, blood containers, and so forth that you're probably familiar with, and all the sample collection side, and then marrying that up to the molecular diagnostic, both assays and platforms, robots that we provide. So we have now one integrated system, and the whole goal, of course, is to provide a solution to both the physician and the patient. So without further ado, I'd like to talk about today's topic, my topic, which is really cervical cancer screening. I spent a lot of time working in that space, and it's been impacted fairly severely, as we will see, by COVID-19. So we want to talk about that and what we can do to address some of those challenges. As you're probably aware, cervical cancer is one of the most common sexually transmitted infection. Infection is a good term for it because it's not really a disease. Most people will clear up the virus on their own, but unfortunately for those where the virus persists, it does cause both precancer and cancer. It's estimated in 2022 about 14,100 women will be diagnosed with cervical cancer, and over 4,280 will actually succumb to disease. So it's a serious problem, despite highly successful vaccination or vaccines being available. But really, the challenge is both coverage on the vaccination side and also on the screening side. So just to give you a little bit of background here, I know not everyone's very familiar with cervical cancer screening. So this is kind of my attempt to put it all on one page, as it were. And the PAP, for those of you who don't know, derives its name from George Papanicolaou, who way back in 1928 actually invented the PAP, which is really a cervical cytology. And the original conventional or dry PAP, as was known and still is used in some parts of the world, was you take a brush or a spatula or both, and you collect some cells from the cervix, and then you smear them directly. The physician or nurse would actually make the sample directly onto a slide, fix it, and then stain it with a so-called Papanicolaou stain. So that was the order of the day, and really it was invented, as I said, in 28. But he didn't get any traction. In fact, people thought he was out of left field until in the 40s. He started to collaborate with some OGYNs, and he published a famous paper, and gradually started to educate physicians in the 50s. And by the 60s in the US, it started to have widespread adoption. Very successful, as we see, in bringing down a heavy cancer rate, but as we see, we have some challenges going forward. So the conventional PAP was replaced in the 1990s with what we call the liquid-based PAP, or liquid-based cytology, or LBC. And this is the same process to collect the specimen using a brush device, typically or a brush and spatula, but now they're placed into a liquid-based cytology medium. The goal here is really two things. One is to enable automation to happen. Of course, with the dry PAP, conventional PAP, it's every user is individually making the slide. But when you get into a liquid medium, you have the ability to control the amount of cells get deposited on that slide using automation, and therefore develop a so-called thin layer cytology. So there are two main brands, the SurePAP and ThinPrep, on the market globally. These have been essentially in large parts of the developed world rather, have replaced the conventional PAP, but the conventional PAP is still widely practiced in places like India and China, etc. So the other change that happened in the 2000s was with molecular biology coming on, we began to look for the virus itself, the human papillomavirus. So of course, the human papillomavirus causes the cytology changes, that abnormality that we're looking for in the PAP cytology. But now we can look for the HPV virus upstream of that damage, and it's a more efficient and a more effective way to screen for cervical cancer. So since the 2000s, we've been doing that in the US using what's called co-testing, using both the cytology and the HPV test together. But the world is now moving, in the case of the US slowly, but the rest of the world is moving more quickly to doing what we call primary HPV screening, where we just test with HPV. If that is positive, we could reflex to cytology or other tests to triage those patients on for further care. The next happening really then is the 2020s. Very recently, we know there's started to produce self-collection tests for HPV. This is done in clinic or at home using a kit. And these are out now in Europe and elsewhere, but they're not yet approved in the US. We'll talk about what the plans for that are at the end. So we have this kind of continuum of continuous improvement here as we move kind of through the ages. So there's still a lot of everything going on and a lot of change going on, particularly during COVID. This is just a recent WHO publication looking at who is doing what across the world. It's a little hard to read this, but you can see that the light blue cytology predominates. You see a mixture of cytology and HPV with the kind of the zebra-like pattern here. And then you have other places where nothing is recommended at all. So we have a mix of things going on. It's clear if we look at a table here to see who's moving to primary HPV screening. And of the 202 WHO countries and territories, 69% have recommendations. Of those, you can see the numbers here. Visual inspection is just a simple acetic acid direct inspection of the cervix. It's not very reproducible. It's really not recommended any longer, but it's used in poor countries where they don't have resources as something that allows them to look for patients with disease and actually treat that in real time. So we have a lot of cytology, as I've said, that predominates with the world. Certainly the developed world is moving fairly quickly to primary HPV adoption. They're either adopting or transitioning to a hybrid system and moving on to do primary. So countries like Australia, UK, Netherlands, Denmark, and others have moved already to it. This is just a kind of a report card, if you will, on the US situation. This is a look at, there are two types of cervical cancers. There's the squamous cancers and the adenocarcinomas. The adenocarcinomas are higher up in the canal, or what's called occult disease, are more difficult to detect. The smaller lesions at the outset in some cases. So what we see here is that despite the PAP, all the way through the 70s, 60s, and 70s, we've got this nice reduction in the squamous cancers, but we have not really impacted at all the adenocarcinomas, and they're a serious problem and cause a lot of morbidity and death. You can see here the two curves are combined. You see this kind of different combined slope, and that's the kind of image that most people have in their heads. But when you break the two cancer types out, you can see that we've gotten reduced the easier to detect squamous cancers. We haven't done a good job with adenos, and that's why we need HPV and particularly extended HPV testing, as we'll talk about in a minute, to detect out those types that are more associated with this disease. So let's move on. Just to kind of bring this all home, where the goal of cervical cancer screening is to identify and treat pre-cancer. It's no good to tell a woman that she has cancer. You need to detect it 6 to 9 years ahead of time as a treatable pre-cancer state. And we typically now, the guidance is based on what's called cervical intraepithelial neoplasia grade 2, which is the highest grade before cancer. And what we're trying to do with cytology is detect that, as a high-grade cytology lesion and then look at it in histology using a biopsy, so to confirm that diagnosis. So HPV testing is very predictive of those who are at risk from that. But as you can see over to the right here, this is data from our large 33,000 strong PMA trial that we did across the US to approve the BD on Clarity assay. You can see here about roughly 15% of folks were positive. So again, 85, 90% of women are negative, they clear the virus. Where you have positivity, you have risk, but then if you distill that down using triage, you can you only tend to detect of those total women by 0.5% SYN3s, that's the precancer, and even less, another drop roughly tenfold or so down to a cancer state. But still, that's still a lot of women over a national community. So the goal, most women cycle through the system as negative, they clear the virus. We're trying to identify those who have persistent infection and therefore need intervention. That intervention, by the way, can be as simple as an ablative technique or a cone biopsy or a LEAP procedure where the tissue is removed. So the idea is to get rid of the precancer before it can develop further and spread. This is a look at the new management guidelines. This came out in 2020 during the pandemic. And we've moved now from more descriptive cytology terms to looking at a quantitative measure of risk. So that's SYN3 plus or pre-cancer state. And the idea is to use both HPV testing and cytology to assess that risk. So there's an algorithm for this that's on an app or a website, and you can go in there and put in the patient's information, age, HPV positive result, negative result, whatever their cytology category was, if known, from the current result and the prior one of record, if they have it, and then it feeds into a personalized kind of medicine algorithm which looks at risk. And the thing about HPV testing is it's not about detecting the virus; it's detecting a bolus of infection that corresponds with a risk for developing precancer and cancer. So it's a pretty high viral load that one's looking at. So you can see here, the first thing the app does, it says, okay, what's the immediate risk, the baseline risk, as we call it, for SYN3? If it's over 4%, then you're referring that one for colposcopy. That's a more involved procedure with a specialist procedure with OGYN, and our colposcopists, they would image the cervix under magnification, do a little staining of that acetyl-white, looking for acetyl-white areas, and then do a punch biopsy where they see some areas of suspicious cells, and then that is sectioned and it's put as histology, standard histology at that point, and they can confirm that diagnosis. And that SYN2 1, 2, 3 grade is really based on the extent of that lesion. So we have, as we see, various risk levels within that colposcopy referral where you're either recommended, you can do treatment, or colposcopy, meaning you just take a biopsy, or expedite treatment where you have very high risk, and you can go right to a treatment, meaning they're going to take tissue away and actually try to treat that patient. Down below, if you fall below that 4% threshold, you're then returned over 1, 3, or 5 years based on your calculated risk for disease outcome over that period. And so this is where we're technically in a 5-year window, but most patients come back in 3. That's largely historical from our prior guidelines. So the current screening paradigm, I'd say globally and in the US, is this kind of 16-18 paradigm, what I'm calling that. What does that mean? It means that if you have a 16-18 infection, you're automatically referred to colposcopy, regardless of your cytology result. It's just, these are the 2 types that contribute 70% of cancers, or traditionally did pre-vaccination. So you now have this, these are the 2 most important types, and the 12 other kind of left as a follow-up later at some interval with cytology and or HPV testing. So you have this kind of mindset that dominates the world today, but there are several reasons now to update that. The first is kind of alluded to already, which is the vaccination. The good news is vaccines are very effective. The 2006 vaccine had 2 high-risk types in it and 2 low-risk types in it that cause warts. But now we know that you were seeing the impact in the clinic with the young ladies who were vaccinated at around 11 years of age are now in the screening pool, and they're showing up with less 16-18 disease. So that changes the dynamic here. So the 12 other pool, it also masks disease, because when you pull things together, as we'll see, you're kind of hiding the overall, you get an average risk, which is really not the situation that you're looking at. And also we've known for a long time that persistent HPV infection is what causes disease when the immune system does not eradicate the virus. So we now know that genotype specific persistence, meaning the same genotype, there are 14 high-risk types, 31 persisting as 31 is more significant a risk than just being reinfected with something else. But this is kind of an attempt to look at the evolution of our understanding of precancer risk over the well, it's 15, 20 years now at this point, but the mindset of 1618 trios was really from the seminal study by NIH back in 2005. And you can see here that they're looking at cumulative incidence of SIN3 risk in 30 plus women over 10 years. And you can see that 1618, as I just said, are really important. But what's kind of misleading here, at the time, they only had the ability to look at 1618 in the study with the assay they were using. But down below, you see the negative line, and also the solid triangle is the 12 other risks, which don't look that risky. But we now know when we break them out and we look at them individually using PCR, we can see that these other types like 18, 31, 33 are quite risky and important, and are certainly not looking like negatives when we actually pull them out and look at them in isolation. So that kind of mindset's changed, and now the guidance is changing with that. So let's talk a little bit about what extended genotyping is. There are really three types of assay available on the market, FDA approved today. There's the original high-risk HPV test called the Digene Hybrid Capture 2 test, or HC2 test. It detects all 14 high-risk types, but there's no resolution of which type it is. So you don't even get the 1618 carve out, and it kind of identifies the two most riskiest types. Then we had partial or limited genotyping, as this is defined, meaning it's all 14, but you carve out 1618. In the case of one assay, Aptima, you carve out 16 or 18 plus 45. It doesn't discriminate between 18 and 45, but 18 and 45 are very important. And adenocarcinomas, so they're related. Then we came along with the BD clarity assay, which is extended genotyping, which means at least 5 or 6 types. And as you can see here, I'm trying to give you an eye chart analogy here, revealing more information, and it's more actionable information, as we'll see. So we have risks. There are different risks that the 14 high-risk types are not all created equal, as we've seen. 1618 are the most important, but then you get into the middle group, and these are the ones that are in the new 9-valent vaccine. They cause the next 20% of cancer. So you want to focus on the top 7 versus the bottom 7. And this is an example of that from our PMA trial or on clarity trial. You can see here that, I talked about that 12 other group, being kind of low risk in people's imagination or mindset, shall we say. But now we know that when we pull out these types, look at 31 here versus 16, it's quite close in risk of precancer. So we get a lot of SIN3s with this type, and we see this in real world data as well from our test sites. And again, 18 is next, and then you move down the food chain, as it were. As a passing note, 66 is no longer considered high risk or cancer causing. It was removed several years ago, but it's still most of our assays. So it gives you an idea of how the risk is reduced in these lower types. And we've pooled those two groups of 3 you see in our assays. This is our assay output on the left y-axis here. You can see also immediately that if you apply the 4% risk threshold that I referred to, which is the new management guidelines that have been laid out here in the US, you can see that 31 exceeds that almost by 2x, and therefore anything with a 31 should, like 1618, be going to colposcopy. We're waiting for that app to update, and that's been a delay with COVID, but we want to include that type and relook at the risks of these other types for precancer and cancer. And just as a reminder of what's going on in the background here, as these women come in who've been vaccinated, this is a Costa Rica vaccine trial, and you can see here quite good evidence for what's controversial literature as type replacement. You can see that in unvaccinated women, the vaccine types that are predominant here. 1618 are in the vaccine, but there's some cross protection with these 3 other types, 31, 33, and 45. Simply the protein sequence looks like the 18 or 45 sequence, so you get some partial cross protection. But in non-vaccinated women, you see these predominate. But in vaccinated women where they're protected, now you see these other types that I mentioned, which are traditionally not thought of as being that important, are kind of moving in, and they're coming up more frequently in the SIN3 disease pool. So not being alarmist here, these will not be as risky for cancer as the vaccinated type, but one needs to be aware that this kind of change is kind of happening, and this will continue to happen both now and in 2030. We'll see the 9-valent vaccine ladies show up in screening, and you'll see them be protected against even more types. So that will change things again. But that's not to say we should stop screening. We should certainly not stop vaccinating. But just to sum up on the 1618 paradigm, we're increasingly focused on the wrong HPV types. Those 1618 types are going down in prevalence, and contributing less to disease. So these other types are coming in and kind of establishing that niche, as it were. So we do need to change the guidance, and that's why we're bringing in the extended genotyping and that Apple update to allow you to access some of these other types that you need to look at. So again, just come back to this pooling concept. It's a little bit tricky to explain, but here's my attempt at it. It's just simple math, basically. So the number, it's basically SYN3 risk is based on the types that are contributing to that risk and their prevalence. So if you imagine this hypothetical situation here where you have this 31 type, which is rounded to 8% here risk, and these others are 1 or 2%. If they're all co-equal in the community, you kind of get an average of 12% divided by 4, which is 3. Again, this is just a hypothetical, but in reality, underneath the surface, you have these 3 types which are not that risky, which could be, delayed to retest at an interval, maybe 1 or even 3 years in some cases. So versus the 31 type, which is colposcopy. But notice on the left panel, everything's below the line of 4%. So you're kind of lulled into this false sense of security. So that was really the 2005 kind of understanding, but now with our new understanding, we need to upgrade and how we treat these patients. And finally, just to sum up on genotype-specific persistence, we now, in the last 5 years, have got very good data that says it's important to discriminate between just high-risk pooled infection versus genotype-specific persistence. And just to get to the point here, look at the yellow dot and the red dot. These are looking at cumulative incidence risk over 3, 5, or 10 years, which is the SYN3 or even SYN2, the prior lower-grade precancer category. You can see that there's a very strong difference between the yellow and the red dot, meaning yellow is just pooled as 12 other pool positive, you don't know what it is, versus red, where 16 is there twice, or 52 is there twice, or whatever the type is. If any of those high-risk types are persisting, it says the immune system is not taking care of it, and it's setting up shop. It's basically integrated into your chromosome and cause cancer, basically over a long period of time. So it's important to be able to recognize that, and that's the best predictor of outcomes that we know of today, I think, in terms of persistence. So again, just to summarize that, we can immediately look at the risk stratification of a woman by knowing what type she has. You can monitor the impact of 16-18 vaccination, and later, 2030, you'll start to see that impact of the 9-valent vaccine, which has 7 high-risk types in it. And also, right now we can use it immediately to identify these women who are at risk for precancer with 31, which is high risk after 16, and higher impact for precancer than 18, which is currently sent to colposcopy. And we, of course, as we said, we can look at type-specific genotype persistence, which allows us to really monitor that risk elevation as we see the virus not clearing. So I like Mark Shipman from NCI. He says, think simply and best. He says the most important thing in cervical cancer screening is what type does she have, and what genotype does she have, and how long has she had it. If you want to know about how to do good cervical cancer screening, that is the crux of the matter as we understand it today. Finally, to cover COVID, unfortunately, the impact has been very severe. As you can appreciate, if you stop going to the doctor yourself for any reason, you see that a 90% reduction. These are little systematic analysis here. You can see that the US and Italy had some sites where we had an average of 90% reduction in service. Here's another very similar plot from Canada, where we can see in Ontario, where you saw the difference between 2020 and 2019, where pre-COVID you had these kind of levels oscillating with time of year, but you can see again a 90% reduction. And interesting, it hasn't come back to full coverage yet either. And even at its best, pre-COVID, 1 in 5 women in the US were never showing up for screening. So we have a problem that's been exacerbated by the pandemic. What is the likely output? You don't have to be a modeler to kind of appreciate that this will very likely, almost certainly at this point, increase the cancer rate. Why is that? Because you have this gap now, and women have, don't always even come back in 3 or 5 years, so now they miss a whole round. That virus, if undetected, it can be growing out and causing a lesion that becomes more serious. So the 2 different modeling studies here, just to kind of net it out. One is different assumptions, but one is saying 4 additional cases per 100,000, which is 40 per million. Over to the right here, you see the similar 38 cancer per million in there. These are different models and different assumptions, but you can kind of get a sense that the magnitude of this is quite severe in terms of the impact. So what can we do about it? I think this is the one of the benefits of COVID. On the one hand, you had this 1 in 5 women who are not showing up pre-COVID, and 50%, that's over 50% of cancers are diagnosed in this group. So these are the women who are not showing up, walking around, they're growing out these cancers. They don't realize it, but present with pelvic pain or other conditions, and then it's oftentimes late at that point. So we now know post-COVID that we have these numbers both on the vaccine side with kids in preschool, middle school, and you have that happening as well as screening as much as 90% reduction in some cases. But on the flip side, we have seen, obviously you're aware, during COVID, we had telemedicine become commonplace. You could for your doctor on the computer. Patients have become accustomed to at-home testing. Technology has emerged. Some of these large labs can send a COVID kit to your home and have the results back in 48 hours. You can monitor what's going on, where it is in the queue, and so forth. So this technology has kind of grown up with the need that was generated by SARS-CoV-2. So how would this work in practice? This is what's already happening in places like Europe, and Australia just added this in clinic as a starting point to their national program. So you could order the test via telemedicine or via some sort of government system. The kit would ship to the home ideally, although it could be done in the clinic also. And then we have now approved 3 different devices in the EU, see Mark, which are these 2 Rovers devices, 2 brushes on the left, and then you have a flock swab, which is probably familiar to most of you in the medical world for collecting samples. So this is a simple 2-minute collection in the home. Again, could be in the clinic. And by the way, if you add it to the clinic, it's important because it now opens up, doctors or nurses or wherever clinics that don't do pelvic exams can now offer this to a woman. And these tests are what we call non-inferior to physician collected in terms of HPV testing. So they're just as sensitive. So we have no loss in sensitivity there. So anyway, once these are dry collected, they're very stable. They can be put into a molecular tube and shipped to the lab. And then the lab can take it from there and test it on an automated system. And then a report up to the LIS and EMR results. And the results can be communicated back to the patient. It's important, obviously, that the physician gets involved at that point, and kind of, if that patient is positive, they would come in for a workup, kind of analogous into a pregnancy test today. I think we'll go like that in the long run, where screening will become more and more common offsite, and then you get worked up in the clinic for those women who need the attention. Remember, 85-90% of women are going to be negative, so it's good to kind of focus on the women who need the care. And how do we get there in the US? There's an already funded National Cancer Institute study, an NIH study, which is called the Last Mile Initiative. It's a public-private partnership between themselves, FDA, and the vendors. And the idea here is to generate, they'll act as kind of honest brokers in this and organize the clinics. They'll collect samples, they'll aliquot them, and then they'll give them to those who want to participate and who have a primary screening claim in the US right now. And we would test those samples blindly, return the results, we get a file and send that to FDA for approval at that point. So this trial itself, you can see the acronym here, is called the SHIP trial, self-sampling for HPV testing, improved cervical cancer prevention. I hope I've convinced you it's an important next step, because again, this, 1 in 5 women, I don't know what the total number is now, but it's certainly more than 1 in 5 who are now beyond the screening window. And just as a reminder, we think that this problem is already here. We talking to the clinicians, they say they're doing more colposcopies, they're seeing higher grade disease today. So even that modeling is coming. I think it'll show up as precancer, and then we'll have a bump in cancer rates as a result. So the way to attack this is to get out in front of it with self-collection and allow those ladies to get screened, because a lot of them, for various reasons, for time or coverage or what have you, or just distance to the physician, or not access inequity in not having an OGON locally, you can now kind of alleviate some of that problem by at least offering the ability to do this test at home or in the clinic when they're coming in for a flu shot or what have you. So with that, I'll end there, and we have a couple of minutes. I think we can cover questions very quickly, or we can wait at the end. I got my last slide here, but basically, I think I've said it already. I'll leave it there for you to read. We have the ability to address this issue with self-collection. Hopefully, we'll get after that next year as soon as possible. and also hope I've convinced you that extended genotyping has real value in assessing a patient's risk for future disease. So thank you very much.
Thank you so much for that presentation, Dr. Vaughn. I'm going to just pause for a second before we have Ms. Molly Broche do her presentation. Does anyone have any questions or thoughts or input that you would like to share? I don't see any questions showing in the chat, and I don't see any questions in the QA. So I think we can go ahead and move forward with the next presenter. But I just, before we start that, I'm not so sure that I gathered enough information or understood really that, this nice, wonderful relationship that's going on between BD and the biopark, and what kind of resources are now becoming available to researchers on the campus.
Yes, thank you for that reminder. We do have a center of excellence that's set up down on campus where we have BD equipment, including some of the equipment that does this testing that I mentioned. So it's there to enable researchers to do work and look at, interesting things. I mean, obviously we're on label for cervical cytology, but we have tissue testing and anal paps and all sorts of oral cancer testing that's going on in a research site. So it opens up that window, and some of these technologies can be applied to different sample types. So yeah, thank you for that reminder.
Wonderful. Thank you for that. I really appreciate it. So with that, let's go ahead and move to our next guest speaker, Ms. Molly Broche.
Excellent. Thanks, Wanda. And yeah, to actually speak for, I'm going to be talking about sexually transmitted infections and vaginitis. And I'm just going to be talking about the disease state during this, but actually the testing that BD offers in relation to STD testing and vaginitis, I believe we also have on a platform, the BD Max, that is at the Biopark, which is very exciting. And just one other sort of plug for University of Maryland, I'm a proud doctorate of nursing practice student now too. So very happy to be able to talk to you all. And, Larry, I think really talked about how much the pandemic has affected cervical cancer screening. Unfortunately, it was not just limited to that. I think when patients were not coming in for their annual cervical cancer screening, they were also missing out on opportunities to be tested for sexually transmitted infections, which really should be a routine test for all women, symptomatic or asymptomatic, 25 years and under, according to the CDC. And then vaginitis, unfortunately, often comes along for the ride and is unfortunately subject to poorer diagnostics. And there are improved diagnostics to really get women the treatment they deserve for vaginitis. So without further ado, I will be talking today about the clinical utility of testing women who present with symptoms for both common sexually transmitted infections and for vaginitis. And the learning objective today are just to really understand the causes of vaginitis and non-viral STIs, to review the current testing methodologies for vaginitis. There have been rapid improvements in diagnostics for vaginitis within the last 10 to 15 years. We have now gotten to the technology that vaginitis can really be diagnosed similar to the way we're diagnosing STIs, which is the standard of care really is the nucleic acid amplification test. And then I will briefly touch on why it's important to test for both vaginitis and STIs for women who present to the clinic symptomatically. So just a little overview of our current sort of sad state of affairs for sexually transmitted infections in the United States. So recent statistics from the CDC that came out post-pandemic show that 1 in 5 people in the US have an STI. And again, this is not just limited to things like chlamydia and gonorrhea. This includes HPV, which really is the most common sexually transmitted infection as well. In 2018, there were about 68 million infections with 26 million new STIs in 2018. And what's really sad about this is about half of these new STIs were among youth age 15 to 24. And this is the population that there is a direct recommendation that sexually active, both males and females under the age of 25, receive this standard testing annually. And what is this costing us? So the direct cost estimate is about $16 billion attributed to these new STI infections. So I think sometimes STIs, sexually transmitted infections, are something that aren't considered that serious in the scheme of things in the healthcare system when you compare to cancer and cardiac issues, but they really do present a pretty big burden on the healthcare system and can really easily be diagnosed and treated with available diagnostics and pharmaceutical agents. And what is hard about diagnosing STIs? So often there's symptom overlap. So when we think about our most common non-viral STIs, so I'll mainly be talking about chlamydia, gonorrhea, and trichomonas vaginalis in this presentation. Unfortunately, a lot of the symptoms of chlamydia overlap with gonorrhea and with trichomonas. So without offering a test that's really looking for the most common non-viral STIs, there's a good chance you could be missing out on diagnosing one of them. Second challenge, often with STIs, there are no symptoms at all. So this is where, really following the CDC and guideline recommendations come into play. And there is a reason for this because, you could come into your annual exam every single year as a teenager, young adult, and never be offered the STI testing. And, I don't know how empowered patients are to actually ask for the testing unless they are symptomatic. So as healthcare providers, I think we really owe it to our patients to sort of in a non-biased way say, for all sexually active men and women under age 25, we do recommend testing for these most common non-viral STIs. As a nurse practitioner myself, I would try to do my best with offering this to all patients that come in because we really don't want to introduce any sort of bias with this. This is just standard tests and, the implications of STIs downstream are it can be very bad and impact fertility and all sorts of different things, but they can be easily treated. So you just want to catch it when it's fresh and treat it. Another problem we often see is co-infection. So unfortunately, these men and women who present to the clinic can often actually test positive for more than one of these STIs. So again, in this presentation, I'm talking about chlamydia, trichomonas, gonorrhea, but I think a lot of people are also at risk for HPV, and there's just a need to not just test for one STI, but multiple ones. So we look at the prevalence here. So what's sort of interesting about this, I think, I traditionally have thought of chlamydia and gonorrhea as being sort of the bad guys of the non-viral sexually transmitted infections. But what's really interesting is STI, and actually it's a cause of vaginitis as well. It's called Trichomonas vaginalis. It's a protozoan parasite. This is actually more common than chlamydia and gonorrhea combined. And one of the issues, I believe, with the diagnosis of Trichomonas vaginalis is most people are still relying on microscopy to diagnose this condition. And unfortunately, microscopy is only about 50% sensitive. Another way that Trichomonas is often diagnosed, it will incidentally be diagnosed on a PAP, but what should be the standard for diagnosing Trichomonas vaginalis is a NAT, or an amplified molecular test. And there are tests available that do test for all three of these conditions together. BD does offer one of those, but Trichomonas vaginalis tends to have some of the same downstream health consequences that chlamydia and gonorrhea have. I know I've been to the CDC STD meetings, and there have been debates about whether Trichomonas vaginalis should also be considered a reportable disease. I think the camp is sort of split now 50-50. But with chlamydia, gonorrhea, you have to report it to your local health department. You have to report treatment. You want to get partners treated. Unfortunately, I think the evidence is still sort of being developed in support of applying these same standards to Trichomonas vaginalis. And right now, chlamydia and gonorrhea are the biggest cost contributors to the US healthcare system, with Trichomonas vaginalis lagging behind. But sometimes I think of that is, again, because Trichomonas, even though it is the most prevalent, even just being diagnosed most often with microscopy, I actually think there's lots and lots of unreported Trichomonas vaginalis infections, just because patients are not diagnosed properly. And again, there is no real rule with partner treatment or having to inform partners with Trichomonas. So I think often half the population is not being reached or told they have this condition. So when we think about chlamydia, so breaking these down sort of slide by slide, chlamydia is most common among young people, with 1 in 20 sexually active young women, age 14 to 24, having chlamydia, and 2 out of the 3 new infections occur among youth, age 15 to 24 years. Again, another really interesting thing about this is about 94% of cases are asymptomatic. So, I mean, one thing to drive home today really is this message that we really have to be screening our asymptomatic patients as well, too. Unfortunately, we are not going to catch the majority of infections if we are only looking at those symptomatic patients. With gonorrhea, sadly, this one has had a sort of historic increase, 111% increase since we actually had a historic low in 2009. There were almost 700,000 new gonorrhea infections in 2020. And what's really scary about gonorrhea is about half of all infections now are resistant to at least one antibiotic. And I know CDC recommendations right now do suggest dual therapy for gonorrhea, so both ceftriaxone injections and azithromycin. And just like chlamydia, gonorrhea is another one that really especially affects young people and can present asymptomatically, hence why it's really important to be screening in this asymptomatic population. And I'll just let everybody read through this, but chlamydia, gonorrhea, and trichomonas, while they do not cause cancer like HPV does, there are lots of serious downstream health consequences that can result from a lingering STI that has not been treated appropriately. So that is the reason why these can present a pretty large cost to the healthcare system. And really, we want to be addressing them and treating them promptly. So just really reiterating this need to annually screen all sexually active women less than 25 years of age for chlamydia and gonorrhea. I would suggest men as well, too, because they are half the problem. And really strongly consider including Trichomonas vaginalis screening in that same patient you are testing for chlamydia and gonorrhea. As you've seen from that data, Trichomonas vaginalis really accounts for more infections in the US than chlamydia and gonorrhea combined. The current sort of standard that's being used in the office, microscopy, unless you are a highly trained microscopist, unfortunately, the sensitivity is just not that good. I think if it's there, people will see it, they will call it positive, but you really have to take the time to be looking at the slide. And the nucleic acid amplification testing that's available now for TRIC is highly sensitive. It takes all the guesswork out of it, and it really allows you to test for all 3 of these through very acceptable sample types for patients, such as urine, vaginal swabs that can be self-collected or clinician collected. You can run it off of, for chlamydia and gonorrhea, you can run it off of actually like an endocervical swab or lipid-based cytology along with your PAP. So lots of available options. I think the important thing is just, when evaluating these patients, to offer them that screening, and in addition to offering, just sort of stating why, and it's these recommendations from the CDC. And hopefully in 5 years, when we look at CDC statistics, maybe we will not have this 1 in 5 scenario. Just moving on to vaginitis. So when we think about vaginitis, this is when I will switch to talking more about a symptomatic condition. But this really is one of the most common causes of women visiting their primary care or OBGYN provider. It results in about 10 million office visits annually. And it's really a broad spectrum of conditions, but per the CDC, when we're thinking about like 90% of the causes of vaginitis, we think about bacterial vaginosis, vulvovaginal candidiasis, or a yeast infection, and then Trichomonas vaginalis. And again, Trichomonas is an interesting one because again, it's a major non-viral STI as well as a cause of vaginitis. So looking at the causes of all these, bacterial vaginosis is really a disruption in the normal vaginal microbiome, where we see this increase in anaerobic bacterial species and a decrease in what we call healthy lactobacilli species. Vulvovaginal candidiasis is a fungal infection. Candida albicans has traditionally been thought of one of the major causes of yeast infections, but we're realizing there's a lot of actually other yeast Candida species that also contribute to this condition and often can be resistant actually to antibiotics or antifungals. And then finally, we have Trichomonas or trichomoniasis. And this is also an STI, and it is caused by that protozoan parasite. And if we look at the symptoms in that very right-hand column, what's very hard about diagnosing a patient's cause of vaginitis without using something like a molecular diagnostic is the fact that these symptoms have a lot of overlap. So it can really be hard to tease apart, even with a pretty thorough physical exam, what exactly is going on. And this just looks at the prevalence of all of these. So BV affects about 21 million women, and there's a prevalence of up to 30% among US women aged 14 to 49. We think about vulvovaginal candidiasis, about 3/4 of women will have at least one episode during their lifetime, many sadly with recurrent episodes. And yeast infections, again, are interesting because this can sometimes be actually induced by the healthcare system by prescribing antibiotics and not giving corresponding probiotics, and certain healthcare conditions like diabetes can also sort of spur on the acquisition of yeast infections. And then finally, we have Trichomonas vaginalis with a prevalence of about 2.1%. Those are some older statistics, though. I mean, again, some of these statistics have been obtained from older data where patients were diagnosed with microscopy, and amplified molecular tests really are the better way to get accurate statistics on this. And similar to STIs, vaginitis can result in serious complications as well, particularly BV and Trichomonas, but there are increased risk for acquisition of other STIs, some negative birth and pregnancy related outcomes. So it's really important to screen and treat for these. And I would say, especially in our pregnant populations, it is important. As I mentioned a little bit before, BV, VDC, and TB have symptoms that really do tend to overlap, which can make it very hard to diagnose these conditions without the use of appropriate diagnostics. Another really interesting thing about these is we mentioned that co-infection with STIs is relatively normal. Co-infection with more than one cause of vaginitis is also very common. I like to point out actually BV and Trichomonas vaginalis are very often seen together because the disruption in the vaginal microbiome that occurs with BV can really contribute to a state where the Trichomonas vaginalis like to live. When we think about our current testing methodologies for vaginitis, we have our traditional methods. So in clinic, so this can be patient exam, microscopy for BV, Amsel's criteria are often used, and then laboratory based. So traditional lab based methods, I think of like culture, gram staining, And then when we think about molecular methods, they're basically broken into sort of two different categories. There's the DNA probe test. There's actually only one on the market right now. This is about 20-year-old technology at this point. It's actually a test that BD manufactures. It's called the BD Affirm. And then we have our nucleic acid amplification tests. BD is one company that offers them, but there are a couple other FDA-approved tests, as well as tests offered by labs like LabCorp and Quest. When we look at these traditional methods, some of the issues with in-clinic testing are the subjectivity and the lack of sensitivity, the degree to which people are trained in clinic diagnosis of vaginitis is highly variable. I think even microscopy skills, some people are highly trained, others really only receive, a day or two of shadowing, and proper microscopy is really critical in diagnosing these conditions effectively if you are going to use a microscope. Culture issue with that, if you're using that as your traditional method, it is a send out test, and it can take up to a week to get a positive result. The nice thing about culture, I will say, is that you often get the antibiotic susceptibility results as well. And then gram stain, this is actually still, per the CDC, considered the gold standard for BV diagnosis. The problem with this is, first of all, not all labs offer it. It requires a significant level of expertise. You're essentially looking at a slide and counting up individual bacterial species. And it puts you in a category like 0 to 3 is negative for bacterial vaginosis, 4 to 6 is intermediate, 7 to 10 is positive. So another issue that occurs there is that a lot of women fall in that intermediate category. And this is just really going over those in-clinic methods again. So for BV in clinic, you can use AMSL's criteria. Another one of the issues with this, not all clinics are going to have all of these available methods for AMSL criteria. Surprisingly enough, pH paper is often hard to find in an OBGYN clinic. I ran into this myself as a provider. WIF test requires potassium hydroxide to be available. And really, for the AMSL criteria to be effective, you are supposed to do all 4 of those tests and only deem a patient positive if they are positive for 3 out of the 4. For vulvovaginal candidiasis and trichomoniasis, again, we have microscopy with a wet mount preparation is what would be done in office. And you're just looking for the visualization of yeast buds or motile trichomonads when looking at either one. Again, there is just a high level of variability in a provider's skill in using microscopy. And I already sort of went over this, but again, the issue with culture is just that time to result. And then with gram stain is this expertise needed to come up with the scoring. And then once you actually get the result, one of the issues is you can have an intermediate result. And this is just sort of going over a scenario of really how sad the state of vaginitis diagnosis is when we rely on patients to try to self-treat, or even when you go to a clinic, sometimes you don't have much success. So, on the pathway where about 50% of patients attempt to self-treat, so this would be like going to the drugstore and thinking you have a yeast infection and purchasing monostat, about only 50% of those patients are treating themselves correctly. For those that treat themselves incorrectly, they're going to have continued symptoms, continued cost, this sort of vicious cycle. And then unfortunately, even when they go to a primary care provider, so you can see from those traditional methods outlined before, even then, about 60% of patients are diagnosed correctly, but 40% continue to be diagnosed incorrectly or diagnosed with a cause of vaginitis that is not what they have. And again, that also continues those symptoms and cost. All right, so the last thing I'm really going to review is just why it's so important to test women, ideally with the same sample, for STIs when they present with vaginitis testing. I think sometimes it's more socially acceptable to ask for vaginitis testing, or patients are more comfortable with that than asking for STD testing. Unfortunately, we found, this is actually a study that BD sponsored, actually using some of our own tests, but women who had BV alone or had a concurrent Candida infection had a rate of co-infection with STIs reaching about 25%. So that means that about 25% of these women with vaginitis, or I'm sorry, with BV or yeast infections also had chlamydia, gonorrhea, or trich, with again, trich being the most common one. So again, we really do miss out if when our symptomatic patients come in, we're only testing them for vaginitis and not for STIs, just because these diseases are essentially acquired the same way, and they really can have those same downstream health consequences. And another reason why it's, really important to, test for multiple causes of vaginitis with one swab is that a lot of women actually can have an infection with 2 or more organisms at the same time. So BV and TB together, or BV and yeast infections together. And there are different treatment sort of dosing regimens, at least for BV and TB, and sort of a completely different treatment for yeast infections. So if you're only diagnosing one and the patient has more than one, you are missing out on treating the patient, which starts again that vicious cycle of coming back to the office. And that is all I have, and thank you for your time. And apologies for going a little over.
Oh, just a smidge, not a problem at all. So I would like to open up our seminar series here to any questions or comments from anyone. I find that this discussion has been really enlightening. I know that there's been a big push for years now for the HPV vaccination for young, for children and teens. So I imagine that, I haven't seen what the outcome of that is, if there are still children who are now becoming adolescents that may be sexually active, if there's been any reporting of how well the vaccination is working for those children. But it's very exciting knowing that there's something that is available given, the concerns with cervical cancer in HPV.
Right. Yeah, if I can answer that one. Yeah, we've certainly made, pre-COVID, we were making some good progress, getting up to 60% or so average vaccination rate in school going boys and girls. It's important to get them vaccinated because it protects against a range of HPV-related cancers. Head and neck cancers are a much bigger problem now for white men in particular. So it's impossible. It's important to get people vaccinated. We did, of course, take a hit, as I mentioned, during COVID. So hopefully we'll get back on track. But generally speaking, we've been seeing both reduction in HPV 16-18 prevalence and maybe as much as 50% reduction in disease. So it's very, very encouraging. We also see other vulvovaginal cancers going down. So that's all very positive, but we can't, we have to kind of bridge that gap now and stay focused on both screening and getting those kids vaccinated. By the way, the 9-valent vaccine is now, you can vaccinate up to age 45. So you can do what's called catch-up vaccination. It is not as effective where you've been previously exposed to that genotype, but it's certainly worth getting the vaccine even later. Obviously, if you get it before the onset, sexual activity has maximal protection. But again, I would encourage, younger or older kids or ladies or boys to get it.
Wonderful. So anyone have any questions? You can please add it to the chat or raise your hand if you like, or we also have the QA feature. And if no one has any comments, then I thank everyone for attending. It was a wonderful presentation, and thank you both for being here. I just want to remind folks again that when you leave out, there is going to be a QA, a survey for you to complete. If you would take a moment to let us know your thoughts and your suggestions for the future, we really appreciate that. And everyone, I'll let you have the rest of your day back.
Thank you very much.
Thanks, everybody.
All right, bye-bye.
Take care. Bye.